Hello friends, in this series of X-ray, today we will see our fifth lecture, that is on lung parenchyma. So first part of lung parenchyma we have seen in fourth lecture. Now this is second part of lung parenchyma. So in this lecture we will cover about bronchiectasis, emphysema, calcification, lung fibrosis, ILD and few X-ray on miscellaneous cause. So let's see bronchiectasis. So first of all, what is bronchiectasis? So bronchiectasis is abnormal dilatation of airway, just proximal to terminal bronchiole. So whenever there is dilatation of airway, it will get more air. So it will looks like a cyst. See, say for example, so this is normal airway. So when it will dilate like this, so it will looks like a cyst with air filled. There is no blood vessels there. So if you see this X-ray carefully, you can find there is hyperlucent cystic-like lesion. Can you appreciate? So this is cystic bronchiectasis. So this is jet black, means complete black. There's no vessels here. So this is bronchiectasis. Here, if you compare with the normal side, this is normal, left side. And if you compare, you can appreciate cystic lesion. So this is bronchiectasis. And if you see CT scan, you can appreciate better. So you can find cystic lesion. And one more thing you can appreciate, because of large cyst, there is collapse of lung parenchyma, collapse of alveoli. So this is cicatricial because of scarring, because of disease. So if you can appreciate, there's little lung parenchyma as compared to this side. So this is lung collapse because of scarring, cicatricial lung collapse. You can appreciate there is shifting of mediastinal towards right side. Can you appreciate? Right side is very small, left side is big, because right side mediastinal shift is there because of collapse. This is cicatricial collapse with bronchiectasis. I hope you are able to appreciate. Now, in this X-ray, you can appreciate on right side, there are cystic lesion. Can you appreciate behind the heart? Okay. So this is cystic bronchiectasis. And one more thing you can appreciate, there is that heart is there on right side. This is right side, heart. One more thing you can appreciate, there is loss of volume on right side and there is compensatory emphysema on left side. So this is bronchiectasis. You see CT scan, this is bronchiectasis. There is no lung parenchyma on this region. So this is cicatricial collapse with bronchiectasis. This is loss of volume. And if you see, mediastinal is shifted towards right side. There hyperinflation of left side. So if you found cystic lesions, it is bronchiectasis. And along with bronchiectasis, there is dextrocardia. So this is case of Carter syndrome. So dextrocardia with cystic bronchiectasis. Now let's see emphysema. So emphysema means dilatation of airway beyond terminal bronchi. Okay. Proximal to terminal bronchi is bronchiectasis. Beyond terminal bronchi where there is no cartilage, this is emphysema. And emphysema, there is restriction of interalveolar septa. So alveoli will distend. There is emphysema, more air collection. So because of more air, lungs will look hyperlucent, more black, jet black. So this is emphysema. You can see this is black lung. And what are the features of hyperinflation? Diaphragm will be flattened. Okay. So normal diaphragm is curved like this. But in case of emphysema where there is more air, diaphragm will push downwards. So you can appreciate flattening of diaphragm. Okay. Now you can see increase irregular radiolucency, means the lung is more black. Increase radioexternal diameter, sorry, interstitial space, and increase EP diameter. So you can appreciate in lateral X-ray. In lateral X-ray, this is external area. This is external. So area between ascending aorta and sternum, this is retroexternal space. So in case of emphysema, it get increase because there is increased AP diameter. So because of increased AP diameter, the increased retroexternal space also. So this is seen in emphysema. Other things, you can appreciate wider space rib. So you can see intercostal space. It is widened as compared to normal X-ray. So this is increased intercostal space. Tenting of diaphragm. Can you appreciate this? Small. This is small. This is tenting of diaphragm. Okay. Another thing, you can appreciate blunting of CP angle. So in this X-ray, you can appreciate right CP angle, left CP angle. So both are blunt, but there is no pleural effusion. So this is pseudo blunting because of emphysema. Because emphysema, diaphragm compressed downwards, and the CP angle will looks as a blunt, but there is no pleural effusion. Another thing is, because of emphysema, there is hyperinflation of lungs, and you can count 10 or more than 10 posterior ribs. In normal X-ray, you cannot see 10th posterior rib. There are exception, means if patient is tall and he can retain means deep inspiratory phase, then you can count. But normally you cannot count 10th posterior rib. But if you are able to count 10th posterior rib, it is mean it is emphysema. Let's see count here. So this is first, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, and 11th. So you can count 10th ribs in case of emphysema. What are the vascular changes? Because of hyperinflation of chest, because of destruction of intervalvular septa, there destruction of blood vessels also. So blood vessels will also be not seen in case of emphysema. So blood vessels give radio opacity. There's no blood vessels, it means it will looks more black. So paucity of blood vessels which are often distorted. So this is case of emphysema. So emphysema mainly three types: centriacinar, penacinar, and paraseptal. Okay. So in this X-ray, you can see the emphysema is there in lower part. Can you appreciate this is diaphragm flattening, tenting, CP angle blunt, intercostal space is more widened as compared to upper side. Lower lobe emphysema. So in case of panlobular emphysema, there is lower lobe predominant emphysema. So this is case of panlobular emphysema. So because of emphysema, the lower lobe, upper lobe are quite normal. So this is case of panlobular emphysema. If you see this X-ray carefully, you can appreciate there is emphysema, blackening, more radiolucency in upper lobe as compared to lower lobe. So lower lobe are quite normal. You can see radiolucency in upper lobe. So this is typical example of centrilobular emphysema, which is common in smokers, COPD or smokers. While panlobular is common in systemic disease like alpha antitrypsin deficiency. So this is centrilobular emphysema. Since emphysema is there in upper lobe, so you may not appreciate flattening of diaphragm, CP angle blunting, tenting. You cannot see because emphysema is there in upper lobe. You can appreciate in panlobular emphysema, but in centrilobular you cannot appreciate. Now coming to pulmonary calcification. So what is calcification? There is radio opacity which is more than bone. So because of calcium, calcium is very hard substance. It gives radio opacity more than even bone. So if you see this X-ray, you can see there are nodules which are very dense. This is calcification. So there are few example which can give this nodules, like a pulmonary alveolar microlithiasis. Then infections. Some infections that healing is there by calcification or healing by fibrosis. So few infection like a histoplasmosis, there is healing by calcification. Miliary tuberculosis, you may see calcification. Chickenpox, or called varicella pneumonia, you can find this calcified nodules in chest X-ray. So this is healing process by calcification. In case of histoplasmosis and tuberculosis, you may find calcification in hilar lymph node also. Okay. Other differential diagnosis, occupational disease like silicosis. In silicosis, you will find eggshell calcification of hilar lymph node here. And the calcified nodules will be there more in upper lobe in case of silicosis. And few metastatic calcification you can find in osteosarcoma, chondrosarcoma, and few benign lesions like hematoma, they are also gives calcification. But typical nodules like this X-ray is seen in healed miliary tuberculosis or chickenpox or pulmonary alveolar microlithiasis. So these are 3 or 4 differential diagnoses with this nodular opacity. So in this X-ray, you can see calcification, irregular calcification here also, here also. So this is case of healed tuberculosis. If tuberculosis is primary, then healing is there by calcification. If tuberculosis is post-primary, then healing is usually due to fibrosis. So this is healed tuberculosis, or if I say healed primary tuberculosis, this is calcification. Differential diagnosis, hematoma. But hematoma is usually single opacity, and you can find multiple opacity in this X-ray. So this is healed tuberculosis. And this is gone complex. As you know, that primary tuberculosis, you can find gone complex, which is healed by calcification. So this is parenchymal granuloma, which is healed by calcification. And you can find hilar lymph node. This is also calcification. And this is healed one. So this is healed primary tuberculosis or gone complex. So this is beautiful X-ray, and you can find in children, some children, because of primary tuberculosis. Now let's see lung fibrosis. So lung fibrosis nothing but cicatricial collapse. So few disease like it tuberculosis is healed by fibrosis. In fibrosis, there is destruction of lung parenchyma, destruction of alveoli, destruction of blood vessels, destruction of bronchi. So that part whole is destroyed, whole is collapsed because of fibrosis. So in this X-ray, you can see this whole left hemithorax is get collapsed because of destruction, because of fibrosis. So what are the signs of fibrosis? You can see mediastinal shifting, you can see opacity, you can see there's narrowing of intercostal space as compared to right side, diaphragm goes up, okay, mediastinal shifting towards left side, tracheal shift, and there's compensatory emphysema on right side. So in common language, we tell as left destroyed lung, but it is actually left side sequestrial collapse, or also called left lung fibrosis. This is right lung fibrosis because of healed tuberculosis. Again, You can find intercostal space narrow. You can find tracheal deviation towards right side. This is also saccasticial collapse. Now coming to interstitial lung disease. So as you know that lung parenchyma has two things. One is alveoli, another thing is interstitial um, structure. So you can imagine this is alveoli. Surrounding alveoli, there is connective tissue which is protecting alveoli. So in this connective tissue, there are blood vessels, interstitial tissue and blood vessels. So this is formed interstitium. Okay. So in normal lungs, interstitium we cannot appreciate in chest X-ray in lateral one third. Okay. So in any case, if you are appreciating interstitium or reticular pattern in lateral one third, it means interstitium is prominent. Okay. So important disease in interstitial lung disease is idiopathic pulmonary fibrosis. So in this fibrosis, there is involvement of interstitium in lower lobe. So lower lobe is getting fibrosed. That is called fibrosis. First, interstitium will get reticular pattern, then honeycombing, scarring. The lower lobe will get narrowed. See, this is lower lobe. So if you know normal X-ray, then you can appreciate abnormality in this X-ray. So in this X-ray, you can find reticular pattern and this fibrosis. But chest X-ray is never diagnostic for ILD. You have to get high quality HRCT done to diagnose a case of interstitial lung disease. So in this X-ray, you can appreciate bilateral lower lobe reticulations and mild decrease in lung volume. So this is idiopathic pulmonary fibrosis. This is classical example of ILD. So if you know normal X-ray, then you can appreciate this is abnormal X-ray. And what is the abnormality? You can find, see, nodules, small nodules. You can find interstitial, reticular pattern. Can you find reticular pattern? So this is like a dirty looking X-ray. So if you know normal X-ray, then you can see this is dirty looking. This is abnormal X-ray. Lot of fibrosis is there. Trachea is going this side, then coming this side. Diaphragm is tinting upper side. There is there are many nodules, reticular pattern. So if you do CT scan, in CT scan you can find a lot of nodular pattern with nodular pattern. So this is case of interstitial lung disease. Again, I am repeating, X-ray is not diagnostic for interstitial lung disease. We have to get high quality HRCT to diagnose case of ILD. But in X-ray, you can suspect. If you know normal X-ray, then you can suspect ILD in abnormal X-ray. So in this X-ray, you can find in lower lobe, you can find emphysema. Can you appreciate emphysema? And you can find that flattening of diaphragm and CP angle blunt and hyperlucency. So this is emphysema in lower part. In upper part, you can appreciate lung fibrosis. Can you see this opacity, upper fibrosis? And in midway, you can see interstitial pattern, means lot of reticular pattern. So if you do CT scan, you can find emphysema. Can you appreciate? This is paraseptal emphysema. Can you see? And if you see carefully, you can see lot of air in between. See, this is air. So this is centrilobular emphysema or centriacinar emphysema. So this is paraseptal, and this small cyst, this is centriacinar emphysema. And carefully you can see subpleural emphysema. This is paraseptal emphysema. So this is case of combined pulmonary fibrosis and emphysema. So both things are there. Emphysema is there, fibrosis is there. So this is end stage of ILD, very poor prognosis when both things are there, usually seen in smokers, combined pulmonary fibrosis and emphysema. Now, you see this X-ray very carefully. This is not a normal X-ray. So if you know normal X-ray, then you can appreciate abnormality in the form of small nodules. Can you see very small nodules, less than 0.3 mm? Very small nodule. So this is bilateral diffuse. So this is called miliary pattern. So miliary means not always miliary tuberculosis. They are differential diagnosis. It's a viral pneumonia, it is tropical pulmonary eosinophilia, it is lymphangitis, carcinomatosis. So diagnosis depends on history, clinical examination, and investigation. So whenever you find miliary pattern, then you have to see differential diagnosis one by one. Okay, so this is miliary pattern like a bajra, very small nodules. This is very important X-ray. You can find lot of nodules bilateral diffusely spread. But you can appreciate if you see carefully lower lobe, more nodules. So this was case of miliary tuberculosis. And if CT scan, you can see lot of nodules, bilateral diffuse. So this is miliary tuberculosis. Now pulmonary edema. So what is pulmonary edema? So pulmonary edema is just interstitial edema and later on alveolar edema. So this is two type, cardiogenic and non-cardiogenic. So in cardiogenic, what happen whenever there is problem in left side of heart, say for example left ventricular failure. So what happened because of left ventricular failure, left ventricle is not able to eject blood to aorta. So there is back pressure. Back pressure means from left ventricle to left atrium, then pulmonary veins. So pulmonary vein get more bloods, dilate. And because of more blood in pulmonary vessels, there will be interstitial edema because fluid will go first interstitium, then it will go to alveolar filling. So first stage is whenever there is left ventricular failure, there is increased vascularity. You can appreciate reticular pattern, especially in lateral one third. Because in normal X-ray, you cannot find reticular pattern in lateral X-ray or upper lobe. Because in normal X-ray, because of gravity, you can find lot of reticular pattern in lower lobe, but in upper lobe you cannot appreciate. So if you are appreciate reticular pattern in lateral one third and upper part, also called cephalization of blood vessels, this is early signs of cardiogenic pulmonary edema. If cardiogenic pulmonary edema worsens, it will involve it will cause fluid in interstitium. And if it is still worsen, it will cause filling of alveoli. So alveoli will get blood, fluid, that filling of alveoli. So how opacity looks like in chest X-ray? Usually bilateral, diffuse, butterfly pattern. Butterfly means pulmonary veins coming through hilum. So whenever there dilatation of pulmonary veins, the opacity will start from hilum like this. So this is butterfly. This is butterfly. Okay. Soft fluffy shadow and ear bronchogram. As I told you, whenever there is filling of alveoli and airway are patent, you can appreciate ear bronchogram. Another type of pulmonary edema is non-cardiogenic. This is because of leaking capillary because of inflammation. It causes ARDS. So clinically and radiologically, it is very difficult to differentiate between cardiogenic and non-cardiogenic. But you can differentiate by few means. You can get 2D codon. If there is a volume load, you can say it's cardiogenic pulmonary edema. If there is small pleural effusion, it may be cardiogenic. So there are few points. There's cardiomegaly, then it probably is cardiogenic. So radiologically very difficult, but clinically you can have suspicion whether it is cardiogenic or non-cardiogenic. So in this X-ray, you can see this consolidation bilateral. Okay, there is cardiomegaly and angles are not seen, very blunt. If you give diuretics, we have given 3 days diuretics, and you can appreciate lungs get clear. So this was cardiogenic pulmonary edema. So you can see consolidation which arises from hilar side and cardiomegaly, and there is CP angle blunt. This is case of ARDS. Again, I am telling very difficult to differentiate clinically. So if you find normal heart size and no pleural effusion, then you can think of ARDS, non-cardiogenic pulmonary edema. But radiologically, opacities are almost same. Fluffy shadows. These are alveolar shadows. Fluffy shadows. Consolidations because of alveolar filling. This is case of ARDS. Now miscellaneous, few other examples. So in this X-ray, you can find irregular, small, patchy consolidations. Can you appreciate? Patchy consolidation. You can find ear bronchogram. Okay. So this was case of patchy consolidation. Okay. If you do CT scan, you can appreciate these are small patchy consolidation with ear bronchogram, which are there in bilateral lung field. So this is bilateral infiltrates suggestive of bronchopneumonia. So lobar pneumonia, if it is confined to a single lobe, if it is spread by bronchi and reaches causing multiple patchy consolidation, this is bronchopneumonia. In general language, we tell as a infiltrates. Some patient have left lung infiltrates, suggestive of tuberculosis, right lung infiltrates. But infiltrates is nothing but patchy consolidation because of involvement of bronchi. That is bronchopneumonia. So this is patchy consolidation. Now, in this X-ray, you can appreciate multiple nodules, varying size nodules. See, small, large, small, bilateral. Can you appreciate nodules? So these are multiple nodules. So if you get CT scan done, then you can appreciate there are multiple nodules with irregular surface, with bilateral involvement, varying size nodule with irregular border. So this was case of metastasis. So nodules which are different sizes, irregular border, well defined, sharp nodule. These are suggestive of metastasis. Okay. And this is last X-ray. You can appreciate foreign body in right lung. So foreign body, if it is made of metal, it give radio opacity more than bone. If it is means vegetable foreign body like a peanut or something like a groundnut, so it will not give so much radio opacity. So you can find this nail in the right lung. So to find exact location, we can do lateral X-ray. Lateral X-ray, you can see this is in lower lobe. So this is case of foreign body, metallic foreign body. So that's all in this lecture. So if you want to understand better, I recommend you to see my previous videos. See you with next video. Thank you very much.